Hello, everyone. Welcome to Midas Live. This is our third Midas Live. The first one was with Hossein Basir, our Chief Product Officer. The second one was with Mark, our product manager who works on our AI products and studio. And today we're with Meena Barsoum, our clinical director. Today we're going to be covering our clinical workflow, and it's going to be an awesome session. I'm sure you're going to have a good time.
Yeah, I'm excited. Thanks for having me, Sina.
Thanks for being with us. So I'm live here from SprintRay headquarters on a beautiful day in LA, and Meena is joining us from Chicago.
Yeah, Chicago, it's pretty nice. You guys will be happy. I have a Paw Patrol marathon going on upstairs, so my kids won't be screaming and yelling in the background, so we can actually get some work done today, which will be good.
Awesome.
Sina, tell me, what's your role at SprintRay? So everybody's aware kind of what your history is and your background. Why don't you tell us a little bit while we wait for the webinar to start?
Sure. I'm a product manager. I currently oversee our software platforms. I've been moving around SprintRay in the past 4 years. Actually, my 4-year anniversary is coming up. I know SprintRay
Awesome.
before it was born. I was classmates with Amir, and Erich was my professor. This is a USC born company. Of some of these ideas of SprintRay was happening when I was a student and watched the company grow, and I've been lucky to be part of this journey in the past 4 years. I've been working on a variety of different products from post-processing and software, and nowadays I'm very much focused on software. NanoCure is one of my babies that started from scratch, and Midas has been a bit fun project for all of us. I think what was missing in our team was the clinical knowledge that Meena has brought to our team. And really, Meena, when did you join SprintRay? You really transformed us since you joined.
Well, I started in May, so this is coming up on 3 months here, just, feeding at the fire hydrant, just learning everything that we have going on at the company behind the scenes and customer facing and end user facing. What I think, and I'll commend you on this, where I think SprintRay and our company really shines is the software. It's the ability to simplify a cloud-based, ecosystem where you can drag and drop a file and it goes right into the slicing software, automatically puts it in the platform, and all those things, as an end user, we kind of take for granted because we're used to that in other aspects of technology, just never in dentistry. So what you've done for us as an end user has made our life a lot easier. So I commend you for that, because no one else even comes close to that kind of experience.
Thank you. Appreciate that. Meena, should we get started?
We can, yeah. Let's rock and roll. So welcome everyone. Welcome to our third session. I'll go ahead and kind of share my screen. My goal today is to kind of go through a systematic review of the clinical side of Midas. Hopefully some of you have Midas and you're using it currently in the practice. What I want to do is kind of walk through some of the different workflows. We'll talk about partial coverage versus, inlays versus onlays, and kind of when we decide. And I'll kind of walk you through some of the why behind it. So let's dive in and kind of go through the history. Like, why are we talking about indirect dentistry? Why is 3D printing and manufacturing outside of the mouth such an important thing? And this is an article that's quoted a lot in the literature. It's a systematic review where the findings were really kind of eye-opening. The outcome of the study confirmed that larger restorations have a higher risk for fracture, since every extra surface included in a restoration increases that risk by 30 to 40%. So think about that. When you go from an MO to an MOD, you just increased it by 30 to 40% for failure. You go MOD to MODL, there's another 30 to 40%. MODL to MODLB, ABCD, all the different surfaces, and now we're increasing that risk of failure. And I think I talk about this a lot. As a profession, we want to come up with a new way to define clinical success. And is it truly, longevity of a restoration, or is it preservation of natural tooth structure, or maintaining vitality of the teeth? So I think that's the idea behind the why here for Indirect. And there's no speaker that isn't self-absorbed, that won't quote themselves. And I'm going to go ahead and quote myself here. A brilliant statement by a brilliant person, Dr. Meena Barsoum. Posterior direct composite failure is the quiet pandemic in dentistry. We've replaced amalgam with a material that demands perfection without giving clinicians the time, training, or tools to achieve it. And I firmly stand behind this. And, amalgam was around forever, and we replaced it because our patients wanted something that looked like their teeth. We didn't replace it because it wasn't working. I mean, amalgams last forever, basically, and the way they function, they rust into place. And when something fails, the tooth fails around it. And that's usually what we've seen. So now we've brought in, direct composites that require a tremendous amount of clinical technique and perfection to make sure that they survive. So that's the challenge we have right now: is are our direct restorations surviving? So this is from good friend Wally Renee, just kind of thinking about why resin. What are some of the characteristics that we see in resin that make it so valuable for us in terms of dentistry? We'll talk about toughness, concept specifically called fracture toughness. We'll understand what that means. We'll talk about the resiliency of a material and why that's important in a tooth when it's under function, under load, and why we need to be careful with that. We'll go back to bonding basics. I think bonding is such an important part of what we do in dentistry, and we want to make sure we understand what that bonding protocol does. And, the biggest challenge we have with any 3D printed material is how does it wear over time? So we'll talk about the wear characteristics and, a little sneak peek into what's coming in the future. So let's talk about toughness. I mean, we've all seen a case like this where a ceramic restoration, whether it's a feldspathic or lithium disilicate or even zirconia, comes in and there's a through and through fracture through the glass. And that's one of the challenges with any glass material, is it lacks this ability to preserve the material. The resins are significantly less brittle than the ceramics, and these ceramics can crack under load. And that's what we've seen over the years in terms of these ceramics. Now, they've obviously gotten a lot better. Our lithium disilicates or zirconias are a lot better, but they can crack. And the problem with a glass material is when it absorbs stress, it tends to want to shatter, versus a resin can absorb all that stress and not shatter it. Those stresses get dissipated through the matrix and they don't propagate cracks like this. It's the analogy we've always talked about with a glass windshield in a car. So that's what we're, kind of fighting in dentistry, is dealing with these materials. Now, what about resiliency? Resiliency is the ability for a material to deform without breaking or changing its shape. So that's what we really want in a material. Our teeth are under constant load every time we chew and function. Dentin and enamel have natural resiliency to it, and what we've done over the years is put materials that are significantly harder that don't have resiliency, and we end up running into situations where that strain can cause something to break. It could be the tooth and it could be the restoration. So we want materials that deform under the stress instead of breaking. And that's a huge benefit to having a resin material, is it will deform itself under stress instead of cracking and shattering. And that's what we want in a long-term material. Bonding is the key to everything we do, and being able to bond something into the mouth allows us to be a lot more conservative. There's a huge push to zirconia. We all love zirconia. I use zirconia every single day. And the benefit of zirconia is I can cement it. But the downside is I have to prepare a tooth for a retention resistance form solution that maybe takes away too much tooth structure, or more tooth structure than I could if I was just bonding to it. So bonding allows us to be a lot more conservative, and that's a huge benefit for us. The other thing with these resin materials is they can be repaired. How many times have we had an anterior veneer case come in and they have a tiny little chip on one of those veneers on a central incisor? What are you going to do? You have to cut it off and replace it. And now you're dealing with a new ceramist or a new technician layering porcelain and making sure it matches. Whereas, with a resin-based material, I can repair it intraorally. So that's a huge advantage for these materials. Now, wear is an important characteristic we need to understand, and my goal in dentistry, at least in this phase of my career, is to replace natural tooth structure. I want to focus on putting materials in there that mimic human tooth structure, and we want to look at the actual wear of a tooth. And there's a study here, if you want to read about this, that goes through the wear of zirconia against natural tooth structure. And we've seen a lot of studies like this, and zirconia can be really kind to the tooth structure unless it's not polished. And if you run into a situation where you haven't polished the ceramic, it can be extremely abrasive to the tooth. How many of us have ever adjusted a zirconia crown? And maybe you're running behind, or you had 7 hygiene checks waiting for you, and you kind of ignore the third and fourth polisher, and you kind of skip it and move on. And that little area that you've just created is going to significantly wear and abrade the opposing dentition. So we want to be mindful of that. And one of the benefits of these resin-based materials is they wear like enamel. So my goal is to replace tooth structure with something that mimics tooth structure, so dentin and enamel, and I can do that with these resin-based materials, and it gives me a lot of confidence in doing that. So let's talk about hardness and strength. And the big elephant in the room is, how strong is this material? And in dentistry, we've been bombarded for years with this specific measure, the flexural strength of a material. Every manufacturer out there will test their ceramics. They go through this testing process with an Instron machine, and this is an ISO standard. It's all done in a very standardized way, and it gives you a measurement. So basically, you're putting a material under load, and you're seeing when it breaks, the flexural strength. And these are some of the flexural strengths that we have of the materials on the market today. Feldspathic porcelain. So how many of you have been a CEREC user for the 40 years that we're coming up on celebrating? That was our material of choice back 40 years ago, was a feldspathic material. That's only 80 megapascals. So when you compare that to Empress or even Emax or Celtra Duo, I mean, look at the differences in that megapascal strength. Now, has every feldspathic material just completely shattered in the patient's mouth if they sneezed the wrong way or if they bit into an apple? No, they hold up, because there's another metric that we're going to look at that's a little bit more important. So we're kind of stuck in this world now in dentistry where I call it high bar syndrome. Which material has the tallest bar, that has the highest flexural strength? You look at Tessera or even 3Y zirconia, they're almost 1,000 megapascals in flexural strength. And what we're learning today is that this measure is not as important when it comes to dental materials as we thought. In fact, there's a more important material that we need to be mindful of, and it's called fracture toughness. Okay, fracture toughness is a measure that determines when a restoration has a defect or a crack, when is it going to break? And that's what really functions in the patient's mouth. And what we want to understand here is, when we look at fracture toughness, my goal is to create a material that mimics dentin and enamel. Okay, so look at dentin and enamel here. We're not going to worry about the actual measure itself, but the number is what we care about. 2.5 for dentin, 2.0 for enamel. That's the fracture toughness. Look at Vita Mark II, the feldspathic porcelain. It's 2.3. It's right in the middle of enamel and dentin. It's an extremely versatile material that moves and has toughness that mimics enamel and dentin, and that's the benefit we have with these materials. Some of the other materials on the market, like Celtra Duo and Tessera, they have lower fracture toughness than dentin and enamel, and some people in the market will report that those materials have had premature fracture and breakage, because fracture toughness really is the indicator that we need. And then even Emax is extremely comparable to dentin and enamel. So I just want us all to understand that when we're looking at comparing materials, we want to make sure we're comparing the same metrics and we're following ISO standards, and all these materials that we're going to be reporting on as we go through this process. The fracture toughness is going to be the most important measure that we look at. Okay.
Meena,
Now,
we have a question in the chat. Maybe we can take a pause here
Sure.
and go over that question. There are many studies that show that bonded ceramics add strength to the tooth, where bonded composites do not. Where do you think that printed materials will fall?
Yeah, it's a really good question. What I want to look at is, again, comparing apples to apples, is when we bond a printed material, what is the ceramic content of that material? Right now, we're at 55 to 60% on some of our materials. We have a 70% material coming up. So let's look at that. Let's study it. And we have universities out there that are looking at all of our materials, that are chomping at the bit to test this. And I can't tell you because it hasn't been tested yet. And I want to see how that functions to compare the two, between bonded ceramics and bonded printed materials. So it's a great question, Doug. Let's look at it. We'll engage with our universities to do some of that testing. Yeah. So the bane of our existence in dentistry is shrinkage, right? We're dealing with polymerization shrinkage. We're taking a resin-based material, we're placing it in the patient's mouth, we're light curing it, and no matter how good you are, how good the material is, there is going to be polymerization shrinkage. And unfortunately, we have these materials now that are bulk fill that you can layer in there 4 millimeters at a time, and it kind of makes us a little bit lazy, makes us cut corners a little bit. I'm the first to admit that I want to get in and get out as quick as I can, and there's a disadvantage to that. It creates tension on the tooth, and it can lead to the stresses that can potentially lead to cusp fracture or microfractures or cracks within the tooth because of that shrinkage. This is a concept we all know about, C factor, that we have to deal with composites. The other problem we run into is the margins. Looking at a SEM 1000X here of a margin in between composites, premium material at 3 years, that is a 8-lane highway for bacteria to get under. And no matter what we do, we're going to have that separation from that shrinkage. This is a very common study that's referenced a lot, and it's looking at the stresses of direct resin versus indirect resin. And you want to be blue in this case, okay? Indirect, look at the amount of stresses on the tooth because it's been polymerized and cured outside of the mouth. That is a huge advantage for us to be able to make something outside the mouth, allow all that shrinkage and polymerization shrinkage to happen before we bond it in the patient's mouth. We're going to get a better seal and less of those stresses on the bond in the tooth. And we all know this as well. I mean, these are dentinal tubules. We are fighting moisture 24/7. Everything we do in the patient's mouth, we're doing it upside down in a wet and dark environment with a patient who's probably annoyed with you. And that's like our world that we live in dentistry. And when you're talking about adhesive dentistry and bonding, we have to be mindful of moisture. So what does our world look like? Four-handed dentistry, you have an assistant in there with a suction, you have your handpiece. The patient is kind of open, kind of not. The gold standard is rubber dam isolation, and everywhere in the world, this is the standard of care. Except in the U.S., we haven't really adopted this globally, nationally, to make this the standard. And I think this is part of why we're probably having some failures in dentistry with direct resins. But we need proper isolation, proper meticulous isolation. Not something like this. Cotton rolls are just not going to create that ideal environment. Maybe Isolite is a good middle ground. I use Isolite all the time, and I think it creates a isolated field that can, optimize bonding. But we have to be mindful of this. We have to be careful when we're bonding. And, the other battle we deal with is matrix bands and wedges and, all the things that make direct dentistry backbreaking and difficult, especially if you're doing a quadrant of direct composites. And, if you're an insurance-based practice like I am, the reimbursements are not great for these direct composites. And it's backbreaking dentistry. It's emotionally draining because you don't feel like you're doing the best work. And this happens to me literally every single time I do this. I place a restoration in there. I design, transverse ridges and marginal ridges and, beautiful anatomy. I take the matrix band out. I take the retraction out. And then I have the patient bite down. And by the time I'm done, it looks like a thumbprint. I've ground away all the anatomy because, I was guessing when I was doing it. And it's frustrating when you end up doing that. And that's part of the world that we live in terms of dentistry. So what have been our current state right now? If you have CAD/CAM, I have CEREC. I've been a CEREC user for 15 years. It's something I believe in. It's something I still use every single day. It's difficult to get into it. It's a significant cost and investment to get into the system, to be able to manufacture chairside milling. Now, this isn't just an Inlay Onlay machine. You can manufacture full coverage crowns and bridges and implant restoration. So it's a different animal, but it's a big cost for a practice to get into if their only goal is to do partial coverage dentistry. You compare that to Midas and a nanocure, where you can print 6 onlays in 8 minutes and then cure them in about 3 minutes, depending on the material, anywhere from 3 to 10 minutes, and you're looking at about a $15,000 investment. So this is 1/10 the investment of a CEREC system. And again, a scanner is not included in here, or some of the other ancillary things, but many of us have scanners. There's 50% of the market that has an intraoral scanner right now, and this is an easy add-on that you can bring into your practice to begin, delivering this kind of indirect dentistry. So it's the current state, and I think things are growing and evolving, and I'm excited to see how these materials evolve. So I want to transition a little bit into preparation design and just kind of talking about how we prepare for these indirect materials, specifically inlays and onlays. And just so we're talking the same language, we all know dental anatomy. I don't need to go over this with you guys again. We have a pulpal floor that we need to protect. We have a proximal box, typically from an existing restoration that was there that we're replacing, or interproximal caries that we have to take care of. And then we'll have a cavo surface angle. So the angle coming from the internal of the cavity preparation to the surface of the tooth. So those are the concepts that we have to be mindful of. We also have to consider pulpal floor depth and an isthmus width. That is really hard to say with an AirPod in your ear and you can't hear it. So cuspal width, isthmus, we have to be mindful of the thicknesses of these parameters, because that will indicate whether or not I do an inlay or I replace a cusp with an onlay. So we're going to follow this here pretty closely and understand it. I also need to know where my functional cusps are landing. So before I prepare any tooth, especially for partial coverage, I always have the patient bite down into articulating paper, and I visualize where the occlusion is. Where's where the functional cusps landing? Where's the centric relation bite? And where do I need to prepare around those occlusal surfaces so I don't leave occlusion on a cavo surface margin, because that will lead to potential failure. So it's important for us to understand that as we're preparing. Okay. Now, a lot of these philosophies are taught at the Mod Institute. Wally Renee and Mike DeFee have come up with these philosophies, and I firmly believe in them, and this is why we're teaching them here as well, because it is a tried and true methodology for coming up with inlay, onlay preparation guidelines. Okay, number one, we need the isthmus to be 1/3 of the overall cusp width. Okay, so I can't have a large isthmus here that is encroaching on the cusps and making them too thin. I also can't have a very, very narrow or thin isthmus. If I'm going to have a narrow or thin isthmus, it's probably a better direct restoration anyway. Okay, so again, we're thinking about what do I have to prepare to get an indirect restoration to function well for this patient. So our isthmus width, isthmus width, I can't do it. 1/3 cusp width. Okay, we're going to call it the IW measurement, okay, just to make it simple so I don't sound like I'm having a stroke. So isthmus width. The depth of the isthmus is 3 millimeters or less, okay? Deeper isthmus is going to require a different preparation. We have to be careful with that. We can't just go super deep, because now we're increasing the material dimensions and increasing the potential for cuspal fracture, okay? Our functional cusp, this is why we take our measurements of our occlusion. Where is my functional cusp here? It needs to be at least 2 millimeters thick. Okay, there's instruments out there you can buy that will help you measure cusp width so you know exactly what the width of the cusp is. My non-functional cusps can be 1 millimeter thick. Okay, so my non-functional here could be a little bit thinner. So if all these parameters fall into place, I can prepare this for an inlay. Okay. If the isthmus depth, oh my gosh, is greater than 4 millimeters, all of you are laughing at me. Try doing it yourself at home. It's not that easy. If it's greater than 4 millimeters, all cusps must be at least 3 millimeters thick. So keep that in mind. If I have a deep isthmus, I need a thicker cusp. Okay, so I can't be at 2 millimeters in one if I have a 4 millimeter deep isthmus. So we got to be mindful of this and how we measure it in terms of our preparation. Okay, I don't see any questions in the chat, so I'm going to keep rolling here. And let's take a look at some images here of an inlay preparation. Again, thanks to Wally and the Mod Institute, we have these graphics here. So 1 millimeter non-functional, 2 millimeter functional, under 4 millimeters deep in the isthmus. Okay, yes, I do sound like Mike Tyson. Thank you. What was it? How did Sarah get to LA? TheraFlu, and it's like a ad for TheraFlu. It's my favorite meme ever. Anyway, Mike Tyson. So 3 millimeters of each cusp if you're over 4 millimeters deep in the isthmus. So super important that we're mindful of this as we prepare. Okay. Use burrs and burr blocks that make your life easier. A lot of these instruments have taper built into it. Let the burr do the work. Let's make sure that we're not trying to create something that isn't there. We want to be mindful of undercuts. We want to be mindful of that cavo surface angle. 90 degrees exiting the cavo surface angle. I want a 6-degree taper, so it needs to diverge, because remember, this is an indirect restoration that needs to seat passively. So these are all the things that we need to be careful with when we're preparing. So my favorite burr block for this, it's Meisinger. It's the SCO2 CAD-CAM preparation kit. I think my title here is blocking it. SCO2, made by Meisinger. Every burr or instrument you would need to prepare full coverage or even partial coverage. I use this for everything. This is a great little burr block that you guys will enjoy using, once you get into this. Question from Gregory: is the cusps flex under loading? Cusp thickness is important to limit that flexure and prevent cuspal fracture. Exactly. So that's why when we have a deeper isthmus, we need a thicker cusp so that we can, prevent that fracture of the tooth and benefit that fracture toughness. Let's look at a case. I'm going to take a case here. This was a case I just did this week. It's a little inlay preparation on a patient. She had an existing MO composite with recurrent decay. And to me, that's a great indication for doing something indirect, because you're probably going to have to increase the preparation size, and it will be a little bit more ideal for a indirect restoration. So we're looking here at our functional cusp, at our non-functional cusp. We're looking at our path of insertion. This is on my PrimeScan 2 scanner. So we captured this scan in DS Core in the PrimeScan 2. I always download these when I'm using Midas as an exocad file. Now, that doesn't mean you have to have exocad to do this. In fact, we're going to do this case without exocad. But the benefit of downloading it as an exocad file is it will download them in a specific file type called a PLY. PLY files carry color, and that makes it easier for me when I'm marginating a case in color. So I've logged into my SprintRay cloud website. I've clicked on Studio. And in the Studio software, I'm going to pick a new patient, and I'm going to choose my treatment type, which in this case is an Inlay Onlay. The first thing you'll do with an Inlay Onlay is upload your scans. STL non-color or PLY OBJ full color. So whatever your scanner is, most of them can output PLY and OBJ. So I'm going to choose PLY here, and I'm going to click open. It's going to bring in my upper jaw and my lower jaw automatically, and it knows which is which. You can tell this was a PrimeScan 2 image. There's a lot of artifacts in there, but even with those artifacts, the software will still give me a good proposal. So I'm going to speed this up a little bit just so you're not watching it. I think we went through 5 cycles of this little animation before the software identified where's my tooth, where's the margin, and it gave me what you'll see here, a really good initial margin proposal. So here's our final cycle here of the AI calculation, and here is my margin placement. So this is all, again, web-based. I'm on a Chrome browser. You could do this on an iPad. You could do this on your phone. And it nailed the margin, I'd say probably 90% of the way. So we're looking at the process here to adjust the margin. And this is where you can be a dentist, right? All of us are going to be dentists here. We're going to go in and really nitpick our margin. We're going to feel bad about ourselves because look at that pulpal floor. It is not flat. I'm a horrible dentist. I should have put a buildup in there, but I didn't. And we're going to see that even with that rough pulpal floor, the concept of additive manufacturing with Midas, I will get an intimate fit with this design. And I'm going to actually have Sina here in a minute print this design for us right on the Midas so you guys can see it. We're going to do it live, and you guys can see the process as we go through this live session. So there's my margination. Now the software is going to go through a calculation to give me an initial inlay proposal. So it's going through the anatomy, it's looking at the adjacent teeth, it's picking a library tooth that matches the adjacent teeth, and it's giving me initial proposal. That looks pretty good. I've had pretty good initial proposals here. I'm going to give it a thumbs up. And we're looking at marginal ridge placement, the contours of the restoration, the proximal contact. Everything looks pretty good. I have some tools here where I can morph and change some of the anatomy. And one thing you'll want to make sure you turn on, there's a heat map that shows you the occlusion. So I want to see where my occlusal contacts are. So I have a occlusal contact there on an incline. I may have to adjust that intraorally. And I'm raising my mesial marginal ridge. I'm checking my interproximal contact. I like a little bit of green on my contacts. So I'll go in here with that smooth tool from underneath and just make a quick adjustment. And there's my inlay. I'm pretty much done. If I want to adjust it, this is a new feature that just rolled out this week. If I get too thin, I'm going to get a warning instantly, and I can tell it to automatically fix it. So now I have a proper design here without any minimal thickness showing. I'm going to go ahead and send this right to my print setup. Now I'm showing you the print setup through the SprintRay cloud. Sina's going to show you an even cooler way where we can do a print setup without a computer, without even a web browser, without clicking on anything. But I'm using the cloud design here, sorry, the print setup feature to automatically position my inlay. I didn't do anything here. It set it up in the right place. It knew where the intaglio surface was. It knew where to put supports and how to properly nest the restoration. I'm going to choose my material, and I'm going to go ahead and send this right to my Midas from this screen. So I'm printing pretty much everything out of Crown HT. It's a really beautiful aesthetic material, something I enjoy a lot. I enjoy using, and we're going to go ahead and choose that. Choose your shade. It knows it's an inlay onlay because we designed it. We'll go ahead and send it to the printer. And now I'll click on my Midas. My Midas is ready to go. My team will go over, they'll scan the capsule, and in about 8 minutes, I'll have the printed inlay ready to go. And why don't we jump to Sina and do this live on the Midas. Sina, take it away.
Sounds good. Meena, before getting to that, let's answer a question in the chat. The question is, how do you present a Midas restoration to your patient versus another composite? And what about the cost?
Yeah, there are two ways to think about this, Kurt. And what I'm going to say is this is going to be individual preference here, because I can tell you two schools of thought that you'll probably agree with. One school of thought for me is if I have MOD, MOD, MOD back to back to back on a patient, that is a nightmare of an appointment that I don't want to sit there and spend an hour, hour and a half doing back-breaking dentistry that doesn't give me a natural break where I can go do something else. So in my mind, even if I charge it as a direct composite, the ability to prep and walk away is valuable to me, even though there's going to be a little bit of an added cost in a capsule. And I could probably fit 3 inlays in one capsule, so it's about a $20 cost for material, maybe a few extra minutes of time, but I can walk away and do something else. And to me, it's worth it to do that, even if I'm not charging an extra fee. Now, here's the other school of thought. This is what I do. I'm delivering a ceramic inlay for this patient. I'm going to charge them for an inlay. Now, my inlay fee is not my $1,200, $1,300 ceramic fee-for-service inlay fee. It's about $100 more than direct composite. That's the way we've positioned it in the practice. And the way we tell the patients about this is, and I still do a lot of direct composites. If it's a small little slot prep or an occlusal, that's going to be a direct composite all day. But if I'm replacing, 2 to 3 surfaces and it's going to be larger, meeting all these kind of minimum factors that we've talked about in the session, I'm going to choose an inlay, and I'm going to explain to them why. I'm going to tell them we're going to design this restoration out of a ceramic material outside of your mouth. We're going to 3D print it, so it's an exact replica that's going to fit perfectly in your mouth. And I firmly believe that this will last longer than a direct filling, plastic filling that I do in your mouth. And I think all of us can probably agree to that this will last longer than direct composite, at least in my hands, with a matrix band and a wedge and a ring and all the complexity and the polymerization shrinkage and all the things that we battle with. So that's my school of thought on this. Now, the other aspect here is when you're looking at onlays. I'm an insurance-based practice, as you know, and onlays are covered by insurance. There's a fee for an onlay, and as long as you have documentation and you can show the reasoning, and we write a narrative for every single crown or onlay that we send out, they get covered, and we don't run into issues with that. So inlays are kind of the wild card, but it depends on what's valuable to you. To me, time is equally important. And I want to get in and out quickly, and I want to delegate as much as I can. And doing this allows me to do that.
Thank you, Meena. I learned so much just watching this, and the Mike Tyson moments were my favorite.
Yeah.
All right, so I'm going to show you a different way to print with Midas. So I'm going to put my computer aside here. I don't need a computer to set up a print job on Midas because there is a mini nesting software on the Midas screen. It's been released lately. Most of you probably haven't seen it. I encourage you to try it. So if you look at here, the cloud icon, you will see the job builder, what we call Autoprint. So first, how do I get my files in there? So if you design within the SprintRay platform, you design in Studio or Cloud Design, every file that goes through the SprintRay platform gets saved into your cloud drive. And once the file is in cloud drive, you can see it on your Midas screen. What if you design a third-party software? We have integrations with Medit, Exocad, and 3Shape. So if you design in Medit, Medit's already sending us the metadata. So it will tell us whether this is a posterior crown, anterior crown, inlay, onlay, veneer, whatever it is. And if it comes from Exocad or 3Shape or other design solutions, we have an algorithm that will try to detect what type of restoration it is. So I'm going to go through this screen and I see this partial restoration that Meena designed. So I'm going to select this file and click on build a print job. And I'm going to be printing with a ceramic crown today. So I'll pick my material and Midas is going to try to build a print job without having to use a computer. Wow, that was pretty quick. So as you see now, we have this print job. I can zoom in, I can look around, and it's nested perfectly. The right orientation, the right supports. Really, there's no need to use a computer and touch anything. I'm going to click on prepare a print job. And now the job is being queued up on my Midas.
So Sina, that nesting was identical to the nesting that I got doing it on the web browser. So the algorithm and everything is exactly the same.
It is the same automation pipeline that now available through API to all of our print clients. This is the first print client that we built on Midas. We're building more. The same print client is coming to Pro 2, is coming through a phone app. There's going to be many different ways to print within the SprintRay platform. And no matter how you print, you're going to get the identical results because it's the same pipeline. So it's telling me that I need one capsule here, and it's asking me to scan my capsule.
So Sina, there's a QR code, right, on the side so everybody could see?
Yes.
And you just hold it up to that little scanner.
Yep.
Nice.
I hold it on here, and depending on the date that it was produced, it knows whether it needs to be primed or not. So this particular capsule needs to be primed. And this is one step that some users miss. So I'm going to go over this with you. So I'm going to click on priming, and it's going to show me this animation. So the process of priming is that I'm going to be holding this upside down, and I'm going to press the white cylinder halfway through, and then the black one all the way in. And I'm going to repeat this 5 times, and that's going to allow me to mix the resin. At the end, it's very important to make sure that the black one is pressed all the way in. And if I remove the red capsule, you're going to be seeing these textures from the bottom of the capsule. That means that it's pressed all the way in. Yeah, perfect. So now I'm going to be placing this in the right slot. And you mentioned 8 minutes. This time it's a 6-minute restoration. So I'm going to be starting.
You must have ludicrous mode turned on your Midas. You know, it's interesting you bring that up. I just learned something today. I didn't know that the priming was based on manufacture date. I thought it was like every other time, just to remind your team, I prime every single time. So if I don't see that priming notification, I don't have to do it.
No, you don't.
Oh, that's awesome. Now, why do we prime? Can you explain a little bit of the benefits of priming and why, it's important to do this versus other resins?
So this is similar to printing with bottles. Before you print with a bottle, if you haven't used it for a while and it's a ceramic-based resin, you'll shake it a little bit. It's harder to do this in a capsule form because it's in a vacuum. If you shake it, it's not going to do it. So priming is going to help all the components to mix together so that you get the perfect results.
Yeah. And these materials are a lot more viscous than other resins because of the higher resin content in them. That's why we need this pressed solution to push that viscous resin. It's kind of like thick honey in there, and that's what allows it to actually print successfully in the Midas. So let's race it. I'll go through some slides here, and then we'll see. You let us know when it's done here, Sina. And then
Sure.
Stephen, good comment here. Don't expose the bottom to light. The other thing is, don't take that seal off of the glass on the bottom and get your fingerprints on it while you're priming. That glass is the glass of the print bed, so you want to make sure that stays optically clean. So always take that film off right before you put it in the Midas. All right, let's see. Let's go back to some of our slides here. So we've sent that to the job queue. A couple of things to keep in mind here when we talk about preparation, and this is a poor preparation. This is one of Kurt Kwiatkowski's cases that he sent me, so I'm using it as an example of a poor preparation. I'm kidding. I love you, Kurt. But when you look at some of the issues here, we have a thin isthmus. We have sharp internal angles, and we have undercuts present. And undercuts are a really big problem when it comes to indirect dentistry because, number one, your restoration is not going to seat fully. So we want to be mindful of our preparation. We have a little bit of injury to the adjacent tooth. And Kurt does that to pay for his boat so he can get more restorations out of it. But then the other issue we're going to see here is when you can't see the margin, you're going to have difficulty marginating, right? So we need to have distinct separation from the adjacent teeth so that we can marginate properly and design properly. And this is out of the software, just looking at the undercuts and how that's going to result in probably an ill-fitting restoration here. So we have to be careful with that, okay? Sharp corners, thin isthmus, this is probably not going to survive very long. If you want to prep like this conservatively, it should just be a direct restoration at this point. If you want an indirect restoration, we have to create the parameters that we've talked about here today, okay? So what's going on here? So again, same issue there with that. Now, what about onlays, okay? How do I know if it's an onlay or a inlay? Now, here are the inlay requirements again. 1/3 cusp width, depth is 3 millimeters or less, functional cusps at 2 millimeters, non-functional at 1 millimeter. And again, anything greater than 4 cusps at 3 millimeters thick. If any of these requirements are violated, you have to cover the cusp, okay? Meaning, if my isthmus width is, if my functional cusps are less than 2 millimeters or less than 1 millimeter on non-functional, that needs to be covered as a full coverage, a partial coverage restoration. So we just have to look at that and understand the mathematics there. Now, look at this radiograph here of tooth number 15. How many of you want to prepare a DOL deep direct composite, place a matrix band on there, and deal with bleeding and deal with all the issues? And that's just going to be a challenging case to do direct. So we've decided in this case to do an indirect restoration, okay? And it extends to the buccal here on tooth number 15. And these are really difficult cases to do. And pre-Midas or even pre-digital dentistry, those of you that don't have the ability to provisionalize an onlay are probably making this a crown, right? I don't think we're all going to go down there and bury cord and put composite sub G and then wait for it to fail. And in my hands, I can deliver an indirect partial coverage restoration because I don't have to worry about a provisional, okay? So here's our scan. We're right back into the PrimeScan software. So this is in DS Core. So here's our preparation. I still like using retraction cord. It gives me a nice clean tissue margin. We have all kinds of diodes and lasers, and they just take me too long, so I'm a big fan of cord. So we have a single retraction cord in there. I can see a nice, beautiful margin. We're going to go ahead and download this as a PLY, and we're going to bring it into our cloud software. Okay, so SprintRay Studio. We're going to click on the Studio application. We're going to start a new patient. We'll go ahead and let's use our demo patient that I just used recently. Let's type for the name. There's our demo patient. We'll click on next, and we'll go ahead and choose Inlay Onlay. Okay, same indication as before. I'm going to find my PLY files that I brought in from DS Core. I'm going to drag them in any of the fields, by the way. It will automatically know which one is upper and lower. We'll go ahead and click next. We'll click on our tooth number, click next, and let it go through its algorithm. Okay, so it's going to go through and figure out where the margin is and, again, optimize a margin placement. I think this one took about 5 cycles as well for the AI to calculate. Okay, so now we're going to have our initial proposal, and let's take a look at where the control points in the margin is. I mean, it was a nice preparation, and it pretty much nailed the margin perfectly. Couple little areas that fell off. But the benefit of AI is, and correct me if I'm wrong here, Sina, but the AI will learn when I make these changes, right?
Yes, the
I
data
think
is
you're
being
muted.
collected. It's not being updated immediately. But all that data is going back to our algorithm team, and we keep improving the algorithm
So
based on the
so we're
feedback.
learning. Yeah, so it's learning based on my decisions, or the team is learning
Absolutely.
and updating the algorithms based on my decisions. So what you're doing here isn't like a traditional CAD CAM system that is on a computer in your office that doesn't connect to the cloud. This is actually giving them the data back. So we'll get our initial proposal here. I've sped this up for the sake of the webinar. Let's take a look at our initial restoration. And, it's a little bit shy there on the distal, and I'm going to go in and change that. And it's not that difficult to do. There was just no opposing there, so I think the algorithm got confused. But we'll take our morph tool, one of my favorite tools, and we can change the size. Maybe I'll make it a little bit larger. And I'll start pulling those cusps down and creating marginal ridges in anatomy. So you see I made it a little bit bigger there so it doesn't distort. And you don't have to be a seasoned CAD designer and an expert in CAD CAM to know how to do this. This is going back to dental school and waxing up teeth. What should a upper second molar look like? Especially one that isn't really in function except for that mesial buccal cusp. So we'll adjust everything here, and just showing some of the tools. Do you have to do all this? Probably not. It's just me being a dentist. I'll go in here and kind of smooth a little bit on the distal, get rid of some of those extreme kind of grooves in there. And that's it. This is the easiest restoration to deliver right now, because guess what? There is no contact to worry about. There's no proximal. There's no occlusal. This is going to print and drop right in. And I've given this patient an indirect restoration in under an hour that I can charge an indirect onlay fee for. And I'm giving the patient a material that I believe in, and I believe it's going to last in this indication a very long time. But more importantly, I preserve that tooth, where instead of mowing it down for a crown, I've kicked the can down the road. Maybe it fails in 10 years, and then we do the crown in 10 years, or however long. We have better materials in 10 years. We'll have better workflows in 10 years. I've bought that patient a little bit more time. Okay. So that's kind of the whole idea behind this workflow, is being able to, preserve natural tooth structure, preserve vital teeth over time. And that's my goal now at this phase of my career, is how do I define that restorative success? And it's looking at those metrics there. Okay, so same process here, sending it to the Midas. We're going to go ahead and print this and move forward. One last thing I want to look at, then we'll take some questions here. I know we've gone a little bit over here, but I think this is good, important information that I want everybody to go through. Actually, Sina, is the print done? Why don't we look at the printer?
Yeah, it is done, actually. Didn't want to stop you there. So the job is done. Let's take a look. It's a pretty strong vacuum. All right, this is our restoration. So once it's done, the idea is to minimize the IPA exposure as much as possible. Ceramic resins hate IPA. It's gonna eat through the resin, and the ceramic restoration will get chalky. So we try to clean it as much as possible by wiping. And during this process, I can easily remove the supports. And
now, Sina, what percentage IPA should we be using? 98% or 70%?
So based on the current IFU is 99%, but we are
99.
validating lower percentage IPAs, because the higher the ceramic content is, the harder it is to clean with IPA. So we're currently at 70% with Crown HT, and we're gonna launch the restore material soon at 70%. So we need to eventually go to lower percentage. So I try to clean with wiping as much as possible. And I always like to have one of these dusters with me, help me dry quickly. You don't want to expose it to IPA for more than a couple of seconds. I'll do one more round of IPA, another round of wiping, and then dry it one more time. And here's the partial restoration. I'm gonna put it in NanoCure. This is ceramic crown, so it's pretty quick, about 3 minutes. Crown HD takes a bit longer to post-cure.
So Sina, you're a lot braver than I with the support removal. I'm a little bit more, I guess, conservative there. So what we do in our office, we have, obviously you're not in a lab setup right now, but just for the clinicians out there, so they know kind of how to set this up, we have a little kind of dish or container that we do all of this work over. So my assistants will actually use the Midas capsule as like a holder, and they'll spray. And then we have a portable air gun that we use, or you could use your lab air. And then so we spray, we dry, remove all the excess resin. And then I like using flush cutters to cut the supports off. I think it leaves a little bit of a smoother surface versus, breaking them off, and it's less post-processing. All right, one last thing, and then we can wrap with some more questions. Just want to show you guys one more thing here on my screen. This is a good resource to have. If you guys go to support.sprintray.com, there are some workflow guides here that will help you with the the bonding protocol. So when you go to support.sprintray.com, let's click on this. You're going to scroll down to materials on the bottom right-hand side, or top row on the right-hand side. Under materials, you're going to see workflow guides. Again, this is right on the website. These are PDFs you can download. For cemented restorations, our manufacturing partners, Ivoclar, Solventum, have put together these really nice workflow guides depending on what you're doing. So let's take a look at the definitive restoration workflow. This eliminates all the questions. Do I need to sandblast? And if so, how many micron medium do I need? And how long do I sandblast for? And what about bonding? And how do I clean it? So all of these different questions that you may have are highlighted here. Polishing for these restorations. We have partners like Meisinger that are putting out polishing systems, and we're going to have a workflow guide that will come out very soon for their new Midas polisher that's really nice. It's a 2-step polisher that gives you a really nice gloss, but all of this is here for you. So if you have questions on workflow, download these PDFs, put them up in your lab, let your team read through them so that there's no question on how to get these in the mouth safely. All right. Any other questions at all?
Well, I don't see any other questions. Well, first of all, thank you, Meena. I learned so much in this session, and I hope everybody else found it helpful. We made a partial restoration. We designed it in Chicago, printed it in LA. That was a fun experience, and I want to thank all of you guys for joining our amazing SprintRay community, joining Midas Live. We're going to have more of these sessions. If you guys have any particular topics, questions that you want us to answer, please let us know. We're going to have more sessions to answer those questions. Thank you, everyone.
Thanks, everyone. Have a good night.